So good afternoon, everyone, and welcome to the BRIE Collaborative Implementation webinar on colorectal cancer screening. I am Amy Etzel, Implementation Manager with the BRIE Collaborative. Before we begin, just a few quick announcements. You all, as I mentioned, are currently on mute, and you will be throughout the webinar. Our speakers would love your participation in a question and answer discussion at the end of the hour. So if you have any comments or questions, please do type them into the Q&A box as we're going along. You can find that at the bottom of your screen, and we'll use that to facilitate our session at the end. We also ask that you enter any technical issues into the chat box and the questions into the Q&A box. We will be monitoring both, but we'll be looking at the Q&A box primarily for that discussion portion. You also may have noticed the closed captioning transcription at the bottom of our screen. In the spirit of inclusivity, the BRIE has been using this feature in Zoom for all meetings, and we'll be using this going forward. If you'd like to view and read the full log of this transcription as we're going along, please look to the bottom of your screen and click on the far right option, View Full Transcription. And then the second option of the menu that will appear is, again, View Full Transcription. This will bring up a dialog bar on the right side of your screen with a log. All slides and a link to a recording of this webinar will be emailed to you early next week, along with a brief follow-up survey that we'd really appreciate your feedback on. So just to start, I wanted to give a very quick background on the BRIE Collaborative itself. We are a public-private group in Washington State formed by our state legislature in 2011. Every year we select 4 to 5 healthcare topics or services that have variation in delivery or outcomes that are used inappropriately or maybe too often, or not used enough, or that have a patient safety or an equity issue that our community cannot address alone or in any other way. And so our recommendations are formed by clinical committee or work groups made up of community members with expertise in the selected topic. This collection of volunteers meets for about 9 to 12 months. And then the work groups, we review published literature, guidelines from specialty societies, the work of other quality improvement organizations, some national entities. We also really try to get patient advocate perspectives and then look at programs and policies within our own delivery systems here in Washington State. So the BRIE Collaborative started offering these monthly implementation webinars in January of 2020 as a way to kind of create a broader learning community and opportunity for you, our statewide partners. In 2020, we were primarily focusing on webinars around our BRIE recommendations related to our behavioral health work. And then this year, we're now expanding out into some other clinical areas. And so if this is your first webinar with us, all of our previous webinars are available on our BRIE Collaborative YouTube channel, as well as on our BRIE website, and links to these 2 places will be emailed out next week along with the slides and the recording. So here briefly is, sorry, didn't realize there was more things in that slide. As you can see, we've worked on a wide variety of topics, starting with obstetrics, looking at appropriate C-sections, and we've also developed best practices for topics such as low back pain and end-of-life care. Our colorectal cancer screening report and recommendation was adopted in November 2020 by our community. And generally, the structure of our reports and guidelines is that we frame them around specific focus areas. So our colorectal cancer screening report identified 4 focus areas to frame the recommendations around, and these are highlighted here on your screen. As part of the BRIE's implementation efforts, I've been developing some starting ground implementation checklists as a companion resource for each of our guidelines. So this implementation checklist, it's really written for clinic staff in an outpatient setting and highlights some of the various actionable steps that clinics and provider teams can take toward implementing our guideline and recommendation. So the checklist will also, on the back side, I'll be sending this out with the slides. It also includes links to some vetted resources that our work group used to create this recommendation. I'm not going to go into a ton of further details right now on this checklist, as the time is really best suited for our experts here with us today to dive into, but please feel free to reach out to me with any questions once you receive it with the slides next week. I'm happy to discuss any further implementation strategies with anyone who would like some technical assistance for this guideline. Okay, now I'm going to turn this over to Ginny Weir, CEO of the Foundation for Healthcare Quality and the BRIE Collaborative Director, to talk a little bit about why we chose colorectal cancer screening as a topic for our collaborative.
Thanks, Amy. So just briefly before moving over to Bev, who is truly our expert here, I wanted to just touch on the equity issues kind of inherent in colorectal cancer screening. And I'm sure everybody's familiar with Chadwick Boseman's death, and the sort of why this happened was one of the big influencers for us kind of framing, selecting, and then framing our areas of impact. Next slide. So we know that Black Americans are more likely, and in fact, 40% more likely to die from colon cancer than white Americans. It's really the second leading cause of cancer death in our country, but has received a lot less attention than breast, cervical, and prostate cancers. And for various reasons, stigma, of course, plays a part. People are less comfortable talking about colorectal cancer, despite it being highly prevalent and having a high mortality rate. Next slide. So when we think about how we want to impact change across our healthcare system, I think our public-private group really lends itself well to being a framework for action. So we think about why high mortality, why disparities in access and outcomes. And here, I love this image. I love flowcharts. So you'll always see me pointing to flowcharts. Failures in this pathway from screening eligible patients until death from colorectal cancer screening, and then wanted to map our areas of impact or our focus areas that Amy touched on earlier to where this is failing along the pathway. Next slide. And then this, of course, led to our 2020 guidelines. So we think about tracking disparities, a registry at a site level. We think about measurement by race, really wanting to be able to stratify by categories of population groups that are less likely to receive high quality care and then less likely to be able to survive colorectal cancer. We think a lot about person-centered care. We try to work shared decision-making into our recommendations everywhere that it's possible, and here have some specific recommendations there too. And then this payment piece is really the underlying factor for a lot of the disparities we see. So recommending paying for a colonoscopy after a positive FIT test. These are often not covered, or those that start out as a screening and then change to a diagnostic procedure. So that is my brief summary. I am now very happy to turn this over to Dr. Bev Green with Kaiser Permanente. Bev?
Okay, I'm being set up here. Well, thank you for inviting me to talk today. And I am happy to talk to you about decreasing the burden of colorectal cancer in Washington State. And I want to acknowledge the working group that put together the recommendations from the BRIE committee and the wonderful members we had. They were nationally and local stakeholders and have been working in the field to improve colorectal cancer outcomes and decrease disparities for many years. And it included Rachel Asaka from the Hutch and Jason, who's worked in disparities for a long time, and Jason Dominance, who's leading one of the largest trials comparing colonoscopy to mailed fecal immunochemical, or not, it is mailed, but to fecal immunochemical testing, which we call FIT. And Casey Eastman, who's going to talk to you later, and also Julie Stoffel. We had strong patient engagement, and Patricia Arbach and from United Health, and Rick Ludwig, just to name a few people. And you can see the full list of people, but it was really a strong committee. And I had very little to do with this because they steered themselves quite nicely. The next. So I think we've already heard that colorectal cancer is the second leading cause of cancer death. It's the third most common cancer. And of the 5 leading causes of cancer death, it contributes heavily. Colorectal cancer screening is important because it's been shown in randomized trials, multiple randomized trials, to decrease colorectal cancer mortality as well as incidence, which is really unique. with colorectal cancer screening, we can find precancers, remove them so cancer does not develop. And we can also find early cancers when they're most treatable. The only other cancer that you can prevent with screening is cervical. It removes precancers, but for breast, lung, and prostate, we actually find early cancers, and that's how we make our effect. Next slide. So this shows the importance of finding colorectal cancer early. The 5-year survival rate is 91% when it's found in the local stages, whereas once it's spread out of the colon, survival is much lower, particularly when it's metastatic and removed from the colon. So it's important to find it either pre-cancer or certainly early before it can spread. Next slide. Colorectal cancer is a cancer mainly of older people, which you can see here. And because of screening mainly, and better treatments as well, but screening mainly, rates have been decreasing in older folks and of both incidence and mortality because of screening. Whereas for younger people, we have a problem. It's increasing, particularly in those under age 50, but at a rate of 2% a year, the deaths, and for those age 50 to 64 at about 1% of the year. Next slide. Because of this, we've had guidelines for many years that have strongly, the U.S. Preventive Services Task Force that makes guidelines for the U.S. that are covered by insurance, strongly has recommended colorectal cancer screening for age 50 to 75 for many years. This most recent update that just recently came out, they now recommend screening for age 45 to 50, whereas the grade A recommendation is based on randomized trials that actually showed mortality reduction and incident reduction. The recommendation for younger age is based on modeling. And they recommend shared decision-making for age 76 to 85, depending on health status. And these are recommendations for average risk people. Of course, people with higher risk or symptoms need different kind of care. So their modeling exercises have shown that all modalities listed here are equally effective, but they have to be adhered to. And they include colonoscopy every 10 years, a FIT test every year, a sigmoidoscopy every 5 years, or if you combine it with FIT, every 10 years. And then the recent Cologuard that you see advertised on TV includes a FIT, and a stool DNA test is recommended. Most groups recommend it every 3 years, but it's uncertain. And CT colonoscopy, which virtual colonoscopy every 5 years. Next slide. So what are the modifiable failures in, we talked about that we have problems, that we have failures, and they lead to increased deaths. And the biggest group is not having ever had any screening or not being up to date, where you can see the risk of a death is twice as high. It's a large cause of the modifiable deaths. Whereas failure to follow up after a positive FIT increases your death for about 7 times. It's still a much smaller group than just not getting screened. Next slide. So I'm going to show you some statistics about problems with disparities in screening that the BRE committees, work group committees specifically wanted to address. And these are national figures that shows screening rates. I think overall, I didn't check this quite, I think the screening rates overall in the US are about 63% now. And you can see that Medicare got dropped off. The 73% is actually Medicare. I didn't notice the labeling was off, so I'll tell you. So 73% is Medicare, and 62% is Medicaid, 46% is commercial, and 39% is for the uninsured. So you can see there's quite a bit of inequity between uninsured Medicaid and Medicare. And the highest rates are seen among managed Medicare or Medicare Advantage, because they require Medicare Advantage plans to report it. And it's actually in the bundle of incentivized metrics, HEDIS 5-star metrics, where healthcare organizations can get considerable additional financial and enrollment benefits for achieving higher star ratings. Next slide. Oops, skipped one. So what about our state? How are we doing with Medicaid? Because I showed you that it's a problem. I don't have the uninsured rates here, but this slide's a little bit old, and I'm pretty sure that Casey is going to show us some newer statistics, but these are the ones that I have that are current for me. But I think these are 2018, and what we saw that these are Medicaid is the blue box in the middle. And you can see in urban counties, it's much higher than rural counties. And then for commercial, the rates are higher. So the same trend, but this is in our state. And you can also see it matters where you live and access. So what is the best way to increase screening rates for average risk people? We are fortunate to have lots of evidence on this. And we now have meta-analysis that put together all these studies and tell us which is the most effective strategies. And direct mailing of fecal kits or FIT to individuals who are overdue increases screening rates by about 22% when you combine all the studies. And the good news is that there's little difference in the increase in uptake by different ethnic groups, education level, or income level. So it works pretty well for everyone, but some groups start lower, but they still get the same effect. And other effective strategies include the flu fit programs. And at Kaiser, where I work, they've been trying to close the gap at COVID vaccines, not consistently. Clinics and sometimes hand out fit kits while giving COVID if people are overdue to vaccines. Navigation, where a medical worker helps patients complete the screening, is also an effective strategy, with patient incentives in some studies showing positive results, but not in all studies. Interventions that are done on physicians and teams are not as effective as these other strategies and can be expensive. Direct mailing of fecal kits is very inexpensive, and some studies have been shown that it can even be cost saving because of the high costs of colon cancer treatment. Next slide. So I'm going to give an example from the research we've done at Kaiser. We used automated databases to identify eligible patients who are overdue for screening. And we found 5,000 patients like this, and they were randomized to either just usual care, which Kaiser is pretty good, or mailed fit, or this plus telephone reminds, or both mailed fit and telephone reminds plus nurse navigation. Next slide. And what we found, these results are from about 2009-10, so I don't think we'd see as much lower, the usual care being as low, but you have to remember these are people that were already overdue. We didn't include the people who are already up to date. But just mailing fits, we got that usual bump. We got about a 24% increase. We got a little bit more for adding a phone reminder from a medical assistant, and then even more when we did the full intervention of mailing kits, reminding them, and also providing navigation with motivational interviewing. Next slide. So this shows the effect of an organized program, a quite large program in Northern California, Kaiser. We're not going to only talk about Kaiser, but I like this slide because it shows what happened after the organization started systematically mailing fits to their overdue patients and keeping them on time. And the program started in 2006, and they mail out over 500,000 fit kits a year. So it is possible to do this large scale. And you can see by 2015, their screening rates were over 80%. And the thing that is particularly remarkable is that blue line going down. That's colorectal cancer mortality. And it seemed to be going down directly in the same direction as screening was going up. Now you can see that there's a slight decrease even before the program was in full bore. They were actually really good at a flex sig program as well, but then they were worried about missing right-sided lesions. And also, not everybody wanted to participate in endoscopy programs. So it was adding this FIT program that really got their screening rates up and accelerated their mortality reductions. Next slide. So we didn't stop there. We tried to translate this into the community, and I worked with Dr. Gloria Coronado, who does a lot of work with CMAR, and we did a large trial with 26 federally qualified health centers in Washington, Oregon, and California that included 40,000 patients that were overdue. We built into the electronic health record a tool for the clinics to identify their overdue patients and to automatically generate the things they needed for mailings and ordering. And the clinic staff would mail these out to overdue patients. Unfortunately, we didn't get the 20% increase that we hope to get, that we know we can get. And that's because it wasn't consistently implemented in all the clinics. Some never even got around to it until the end of the year. The clinics that did implement well, and that was 75% of the kits went out, was a good implementation. They had 18% increase. So we learned in other, doing other aspects of research that the busy primary care clinics struggled to do this. And those that had a centralized quality improvement facilities that could do it outside of the day-to-day care or had a dedicated staff person were the most successful in doing this. So we figured, how can we help clinics to do this better? And we worked with Medicaid health plans, two large Medicaid health plans, one in Oregon and Washington, to get their enrollees up to date. And the Medicaid health plans use vendors to do the mailings, and one used a lab, one sent them back to the clinic, and they got the expected rise that we expect to see of about 18%, with not much difference by ethnicity group. I think Asian subgroup did a little bit better. However, it was a 2-year program, and in year 2, the Washington plan dropped its program, while the Oregon plan grew its program, which is being maintained. Next slide. And so why? And this is the difference between Oregon and Washington between 2015 and 2018. You can see Oregon was increasing in their screening rates. Well, Oregon decided around 2014 that they were going to require Medicaid health plans to report their colorectal cancer screening rates. And they also incentivized it in a package of incentives. It wasn't individually, but it was part of the package of things they could do to get increased payments. And this led to the plans being much more invested, and they work directly with the clinics to get their rates up. Whereas we don't measure it in Washington State, and our rates are flat. I know Casey's going to show you some other money. The Department of Health's been very successful in getting CDC monies, and that has actually helped our state, but we have to go and apply for those monies each year. This program that the incentives that they were using in Oregon were statewide and implemented regardless of getting grant money. Next slide. So we, as a group, when we were thinking about how can we support these effective strategies, we thought, well, we had to learn something about the metrics. How can we change these? How can we change these in Washington State? And we started asking a lot of questions. And the one thing that really surprised us is we found out that Medicaid, CMS was trying to make Medicaid a bit more like Medicare and apply screening metrics that would be required in future years. And they already had a list of things that they wanted the health plans to measure. They didn't apply it consistently because they're easing into this program, but they already were measuring cervical cancer screening and breast cancer screening, but colorectal cancer screening was not on the list, despite those large disparities I showed you. And it's understandable, prior to Medicaid expansion, that Medicaid mainly reached women and children, but with expansion, it's really grown. In fact, with COVID and the Healthy Families Act from COVID and allowing different methods for attestation of low income, Medicaid in our state has increased by 12% in this year. So we now have a lot of patients that are age eligible. And as I told you, rates are increasing. So we went to town to see if we could change this on a national level. And we also been working with the Bereaved Committee to change it on a state level. So next slide. So we enlisted other stakeholders, which we found out that they could be really strong proponents, the people that were working in this area full time. And I tried on my own to make a change with the working group that makes these decisions in 2018 and failed. But this year we got stronger support. They nominated the measure. We had to meet all the requirements. Will it improve healthcare? Will it align with other reporting programs? Well, we said we're already doing it for Medicaid. Has it been validated and done? Well, it's been done in Oregon. Is it feasible? And does it fill a gap? And also I'd add, does it decrease disparities? And so next slide. So the good news on May 6th that the metrics committee for Medicaid for the core metrics voted 100% to approve it. Now CMS still needs to approve this, but given that getting 100% vote is very unusual. So we expect that now nationally Medicaid will be required to do this. What the states do with this though is it's one step. So how they do this, how they emphasize it, it's going to be up to the states, at least for the near term. Next slide. So this brings me back to what did our committee do and what did we find important based on our evidence review, the literature and the expertise of the committee. We recommended that we measure it. If you don't measure it, you don't know what your rates are and you don't know what the disparities are. So we wanted it measured by health plan. As I mentioned, it was not required for Medicaid, and by race and ethnicity. So we could, race and ethnicity is not a biologic construct, and we'd like to do better at self-reported report. But if we don't measure it at all, we don't know disparities. And we want measuring of screening rates, follow-up after positive tests, because FIT is a two-part screening test. You have to get the colonoscopy if it's positive, or you won't have any benefit. And also mortality rate. Is your program working the way that you think it should? And also to track it. Short term, we think that health plans and healthcare systems should be tracking their colorectal cancer screening rates. Our aspirational goals would be to have a state registry. So if people switch between health plans, we would know what they needed. It's colonoscopy, it's 10-year interval. So if you don't know, you might do a colonoscopy too early, and that would be waste. And then also we recommended outreach with these tracking programs particularly to prioritize marginalized populations. Next slide. Well, also the strong focus on patient-centered care and shared decision making based on risk, health status, and preferences, and with particular attention that people should pay attention to symptoms, and that our recommendations for screening apply only to average risk people, and that high risk people need to have different surveillance schedules. And then offer education on sedation options, including no sedation. And then also to develop a cost calculation worksheet to show return on investments. As I mentioned, because of the high cost of colon cancer screening, some cost assessments have shown that health plans can actually save money. And these are important to show. And then the recommendation to tie provider plan payments to their screening and other outcome rates to showing improvement as they did in Oregon. And then importantly, to waive cost shares for colonoscopy after a positive FIT. Some people have cost sharing insurance that they have to pay, and they may have considerable expenses. And there are many organizations that do this already, but it's not uniform. We need to make this uniform throughout the state. And also, if a polyp is found during screening, which I think has been fixed for Medicare, but that doesn't apply to all health plans. And providing, this is, I think, the most important. There's a breast and cervical cancer prevention and control program that was approved by federal legislation that provides free screening and follow-up and even cancer treatment for people who have no insurance or are underinsured. But we do not have any program like that for colorectal cancer. And we, I think aspirationally, and really importantly, if we could do this in our own state, it would be critical. And next slide, I think that's it. No, I have a summary slide. Next slide. So in summary, colorectal cancer is important. You have a 4% chance in your lifetime of developing it. Screening decreases mortality and incidence. Disparities need to be identified and addressed. We know what works, and we need to motivate plans to do it. And we know also that it may not be the top thing they want to do. I think like behavioral health is now a really strong, important thing. Of course, COVID. But we know what to do for colorectal cancer, and it's actually not expensive, it may save money. So to get that out there, we can actually fix this. And we need to pay attention and measure the entire screening cancer control continuum. And finally, the BREE committee recommendations address these gaps. And that's it. Thank you.
Thank you so much, Dr. Green, such valuable information. Now I'm just going to turn it over to Kelly Shaw with the Breast, Cervical, and Colon Health Program and Casey Eastman. I think Casey's going to speak first. Is that right? If you guys are there.
Yes, thanks, Amy. I'll get us started. So as Bev mentioned, I was a member of the panel for the BREE recommendations, and it was fabulous to work with all the folks she mentioned and hear their expertise about recommendations that would be helpful here in Washington. We will send out the data that Bev mentioned around some of the state programs and how we've seen some of the metrics that indicate what's happening in the state, particularly with our SQHC partners, the HRSA data that gets shared, how we've seen that change over the years. And the reason she mentioned us is because our program has been working with federally qualified health centers through the CDC program that she mentioned, where we apply and get money to support implementation of evidence-based interventions to increase screening. So I just wanted to share a bit about that, and that we'll send out some data that we look at to see how that's changed over time. And then I'm going to turn it over now to Kelly Shaw, who's the program manager of our Breast, Cervical, Colon Health Program, to talk a bit about some of that work in more detail and a little bit of the success stories.
Yeah, thank you. I appreciate the opportunity to share just very briefly about our program in Washington and some of the lessons that we've learned that are very, very consistent with the recommendations from the BREE Collaborative. So I'm excited to do that. Washington has operated, the Department of Health has operated a CDC-funded colorectal cancer screening program from 2009 until 2020. And we actually at that point, during that program, we paid for screening fits as well as follow-up colonoscopy. In the year 2020, CDC decided to stop funding the screening aspects of that program and reshift the focus to really one of health systems improvement work. I put up here that we, our program for breast and cervical cancer, and while we had the CDC screening for colorectal cancer, we use a centralized database. I know that the BREE Collaborative has some recommendations around registries for fit tests and follow-up. And so I did want to mention that we did maintain this centralized database for people that were screened under specifically under our program during that time. And we continue to use that database now for both breast and cervical cancer screening that's done through this program. So I mentioned that our colorectal cancer program at this point focuses on health systems improvement and to increase colorectal cancer screening rates for low-income, uninsured, and underinsured individuals. So with that work, we're working with a total of 6 federally qualified health centers right now, with a total of 55 clinics across the state. Those FQHCs range in screening rates from about 25% to up to 54%. CDC requires that the clinics we work with all have rates that are under 60% to start with. I will, before I jump into the lessons learned, let me just share that the work that we do are around implementing evidence-based interventions for colorectal cancer. So that would include things like patient reminders and recalls, reducing structural barriers to getting tests, whether that's just access to those tests. And so things that the clinics are doing around mailed fit tests that Dr. Green mentioned earlier. We do have some limited funding to allow for follow-up colonoscopies for people that are receiving the fits at these particular clinics that we're working with. Some other EBI or evidence-based interventions that are being done at these clinics are a provider reminder and feedbacks. Some of the clinics have very robust tracking, and they share that data with all of their providers on a regular basis. And then provider reminders, either through electronic health records or things like daily huddles with their staff, where the MAs have scrubbed the charts the day before or the morning of, and letting the providers know who is due for their colorectal cancer screening. So then the lessons that we've really learned, if you can go to the next slide, please, are really that identifying a clinic champion is key, and that from our experience that it doesn't necessarily have to be a physician champion, but it has to be somebody that's really willing to take on this work. And of course, especially during COVID, we've had some limited capacity within our community-based clinics to do some of this work. But I will say that throughout the COVID pandemic, the clinics have been really rising to the challenge with making sure to continue to get fit kits out and to get folks in for screening. I think Dr. Green also mentioned this, but the importance of patient navigators has really been highlighted through our program. The navigators are just central to making sure that the patients are well informed about the fit kits and the instructions to perform those tests, getting the fit kits sent back, and then follow up for any abnormal fit tests. The federally qualified health centers have EHR challenges in reporting data and tracking data. And so I know, again, where there's been discussion about a registry, a fit tracking type registry, I think that would be very helpful with some of the clinics that have the challenges in tracking those tests, and then making sure that patients are following through for any positive results that they get. Again, all of the FQHCs, there's not one standard EHR that's used across them. So there are many different EHRs, and it's and some of them have changed recently. They've gone from one EHR to another, and so that's created challenges in just even reporting their screening rates, for example. And then lastly, and this is again consistent with what Dr. Green was speaking to, is that We no longer are able to pay for CRC screening for low-income and uninsured folks. So, and that is a true challenge for many people, and some clinics haven't been doing this work because there is no payment mechanism any longer for low-income folks. And again, the issue with the follow-up colonoscopies will be an ongoing challenge. So with that, that's my piece, and thank you.
Sorry, I lost my capability to unmute myself. So thank you so much, Casey and Kelly, for sharing that information with us. I now wanted to turn it over to Julie Stoffel. She was a member of our work group last year, and she was really spoke to that patient and family perspective around colorectal cancer screening. And so, Julie, are you with us now? If you could unmute.
Yes,
yourself.
hi, yes, I am.
Hi, Julie, thank you.
Sure. So I got involved because of cancer. My wife had colorectal cancer, and it was a fairly traumatic experience for us. Not the least because actually she was up to date with her screenings, and she had basically 4 false negative fits with a stage 3 cancer diagnosis. So, you know, things have been better. She had successful surgery, had some follow-up surgery. But one of the challenges that it turns out for us was, how do you determine what is a average risk versus a high risk person? So my father also had colorectal cancer 20 years ago. So I am clearly in the high risk zone. So I just get my colonoscopies at the appropriate level, at the appropriate interval. But for example, I've had 3 colonoscopies, I think, so far, and have never had a polyp. However, it turns out that my wife's family, there was no history of cancer. We found out after the fact, after her diagnosis, that actually both her mother, her father, and her brother had all had colonoscopies and had all had polyps. As well as she's got a high BMI. So those risk factors were actually not discussed by the physician, and it's not really discussed by the the general information about colorectal cancer. I think a lot of people, if they know anything about colorectal cancer and high risk, it's, do you have cancer in your family? And a lot of times families don't talk. I mean, obviously, if you have, like with my father, cancer, because it's a big deal. But if you have a colonoscopy and you have polyps removed, the patient may not even remember. And they certainly probably won't chat about it around the dinner table. So it's a little bit hard to figure that out. So I definitely appreciated working with the BRE and learning all about the cases where you don't have, where people are not even screening, which is terrible. And I was very excited to hear today from you guys that the reporting mechanism has been added to Medicaid, which is great. So it's because it seems like that made a huge difference for Medicare patients. I still wish that there would be more discussion around what is high risk versus what is average risk. And I know that there's, in certain cases, you kind of start with the assumption of high risk, and you have to demonstrate that you're not of high risk for some medical conditions. I think that would be, sort of an opt-in rather than opt-out. I don't really know what to call it, but it's, I think there's a lot of people out there who actually are high risk that don't consider themselves high risk. So they're kind of missing out. The other question that I always have is, gosh, how is it possible to have 4 negative fits with a stage 3 cancer diagnosis? Still don't have an answer to that, but just something to folks to be aware of, I guess.
Yeah. Julie, thank you so much for sharing that story with us, and really for being part of the group, because that patient voice and raising those questions is just so important for all of this work. Bev, I wonder if you could speak a little bit to some of those sort of uncommon risk factors, and if there's been any momentum around or in that area in the work that you've seen and the research that you've been doing.
Well, I think, with the change in the U.S. Preventive Task Force to go down to younger age and the increasing incidence, there has been a lot of focus on younger groups and also symptoms, because I think even going down to age 45 is not going to make as much of an impact if people don't pay attention to symptoms like blood in their stool. Or doctors don't pay attention to that, because those aren't people that should have average risk screening. But there's also this trade-off. We're talking about population-based screening, and I showed you the incidence of colorectal cancer being much higher in older age. So as you expand the population, you also have to expand colonoscopies and capacity to do that. And there's limits. So one of the things that FIT does in the average risk group, it differentiates those who are likely to be higher risk. It's not perfect. And I don't know about doing 4 in a row at the same time, but over the years, it tends to, those people that have microscopic blood, it misses it at random. So it misses it about 25, depends on the test, but 10 and what sensitivity they set it at. But it misses it about 10 to 25% of the time. But next year you'll have that same risk, and hopefully we catch it. And there's a long half-life for going from a precancerous polyp to an actual cancer. I mean, there's exceptions. There's different cancers that are more aggressive in younger people. Certainly we pay more attention to family history, but as Julie said, it's often hard to know if your family had polyps or whether they were precancerous polyps. So there's a lot of trade-offs. So the idea is to get as many people screened as you can, to pay attention to symptom and risk, but realize that there's trade-offs and get as good a test as we can get.
And then Kelly, there's a question that came in through the Q&A in the chat. What about the role of genetic testing for Lynch syndrome?
I'm not expert in that field, but if you do have a family history of cancer colon cancer before age 60, it definitely requires a discussion and possibly a genetic referral. I would recommend that actually as a primary care physician. And it again, if we can recognize the people that are higher risk and get them tested, we can do things about it to prevent them from having colorectal cancer morbidity and death. But recognizing it is the main problem. And, genetic testing, it's already there, and when it'll be commonplace, sometimes it looks promising. Sometimes.
Yeah, there's definitely a field that's making fast advancements.
Yeah, right.
I was also a little bit struck by wondering and thinking about BMI as a risk factor. Is that something that you see providers thinking about in terms of colorectal cancer screening, or is that?
Well, age trumps lifestyle risk by far, but maybe that is part of the younger increase, that it might be lifestyle related and also change in diet. We have more colorectal cancer in the US than many other places.
Interesting.
But whether they're strong predictors, I don't know that.
Okay.
And they're common, right? So overweight's a common problem in our country. And poor nutrition is common.
I haven't seen any other questions come in, so I'm just going to keep throwing out my own. And this one is a little bit possibly more for Kelly and Casey, but I'm struck just in the past practice facilitation and technical assistance work that I've done where population health comes into play, and thinking about registries and some of the smaller FQHCs I've worked with that maybe don't have an EHR that supports good population health and registries. I wonder if you have any examples of how to build a registry that's not based through your EHR, if you've seen any innovation there in some of the clinics you worked with over the course of your programs.
Yeah, Casey may be able to speak to this better than me, but I know that we have worked with our partners at the University of Washington to develop a Excel-based fit tracking tool that is still in practice today, and we encourage that for some of the smaller FQHCs that don't have the kind of more advanced EHR systems in place. Casey, can you speak to that a little bit more?
Sure, Kelly. Yeah, that's a great example. That tool was developed, I think, in 2016, and we have a couple versions out there where partners have adapted it. And that allows them to track when a fit kit has been mailed to the client and then the return. And then some of them do have the capability to track if they've gone on and gotten a follow-up colonoscopy after a positive fit, which is really, really important that that happens. And so that's a lot of the support and conversations now with the folks that are in the learning collaborative with DOH, is making sure that there's a workflow in place to follow up on anybody that has an abnormal male-based fit and make sure that they get the support they need. And often that's via navigators to get into colonoscopy. And then I will say, because of the funding we received from CDC, and the prioritization on folks being in their readiness, there is a pretty big data requirement for baseline data at the federal level that we aren't able to directly fund and support clinics that don't have an EHR. So though some of their EHRs don't have the capacity to track all of the different things and have a registry per se of folks that have received a male-based fit when they returned it and getting into follow-up diagnostics, they do have EMRs. So Amy, to your question, we haven't had anybody that has no EMR in place because they wouldn't meet the federal requirements for the grant.
Okay. Is that Excel spreadsheet tool something that you could potentially share to go out as a resource with our webinar?
I think we can talk to UW and make sure that they're okay with that. I think that because it was developed under a grant, that they just ask folks when they use it to let them know that they've used it so they can report that it's had an impact and how far it's gone. But we can definitely reach out to them and get back to you on that, Amy.
I appreciate that. So we have 5 minutes left. I don't see any other questions coming in. Is there anything that the three of you would like to share as kind of final thoughts or words of wisdom around this topic? No pressure. We can also.
I have a question. What are the next steps after the recommendations are made? How will we know if they have an impact? What happens now?
Is that directed to the Bree or to?
Yeah, to Bree.
Yeah.
To you and Julie. No, I mean Jenny, excuse me.
Jenny, yep.
Yeah.
You know, we really don't have a specific plan in mind. As we're developing our topic areas for 2022, we're toying with the idea of picking a topic to, you know, how we've designated a topic and developed a work group. We're thinking about potentially designating an implementation topic and focusing for a year on working potentially with a pilot group or something along those measures. As part of the implementation resource suite that I've been building, I have been developing some core process measures, not necessarily patient outcome measures, but as I focused in on the behavioral health work, I was developing core process measures around workflows. And so that'll probably be the next step for this particular area as a resource for clinics who are just starting to build up their programs. That will be something that we'll be thinking about as well. And we're always welcoming ideas from you as to how to implement. You know, we don't have the authority to sort of mandate anything. And so beyond sort of this learning collaborative, in terms of implementation, it's really about just providing resources to the community at this point.
Jenny, can you maybe comment on the health authority, the relationship between the health authority and Bree?
Sure, happy to. So our main implementation pathway again is through the healthcare authority, right? So they are meant to take our recommendations and incorporate them into their contracts as a purchaser for healthcare. And I know that they are very enthusiastic about colorectal cancer screening, and it is one of the metrics proposed for the multi-payer primary care work that they're doing. So a couple different mechanisms that they could work to change clinical practice, but that contracting one and then the multi-payer initiative, I think are our main areas right now. Is that helpful, Bev?
Yes, I think it's kind of, we want these things to actually go forward, and, you know, and I'm very interested at the policy level, how the state, you know, because we do have the state disparities. So, and we have a lot of resources, as you can see, but, you know, we need to figure out how to sustain some of these programs and at the state level, and it requires, you know, ongoing discussions.
We did have a question come in about a place for patient education materials in different languages, and just from the BRIE perspective recommendations, you know, we do recommend patient education materials, and then we are always sort of putting that lens of cultural competency and cultural humility. And so making sure that you have the patient education materials and the patient decision aids in a robust area of languages for best serves your patient population is very important. Anything to add there, Bev or Casey or Kelly?
Yeah, I would say, Amy, when you send out the materials, if folks haven't gone to the National Colorectal Cancer Roundtables page, they have a ton of resources and tools, and they even have some audience testing for different populations. So if areas are tailoring messaging to the different languages that they serve, there's some ideas and some audience tested messaging there that might be helpful.
Great,
Yeah.
thank you.
Yeah, the roundtable is a great resource. The ACS and CDC also have pages, but they have pretty good links. Also, Gloria Coronado has a mailed fit page that has translated materials and pictographic materials that without wordless instructions for doing fit.
Great,
And
thank you so
other
much.
things and materials about colonoscopy after a positive fit.
Great. Well, thank you so much, everyone, for your participation and for sharing your expertise with us. And we just really appreciate your passion in this work.
Thank you for inviting me.
Thanks, everyone. Have a great afternoon.
Thank you.
Bye.